Well, good evening, everyone. Welcome back to our Exam Pro webinar series for the 2022 ABOG oral board exams. This one, again, being recorded and archived for us Thursday, September 15th, 2022. I'm your host for this evening again, Rob Pegues. Welcome back to everyone. We are doing case list review since it is Thursday. Thank you, Dr. Takoi, for having your hand raised. And please, anyone else who would like to participate, go ahead and click the raise your hand button and we will get started right away here. Just get rid of that. I think we got our case list sitting right here. There we go. Let's see. So thank you to all our candidates. Let's start in with Dr. Card, because she has been sitting here with her hand raised for several minutes here. I'm going to work on for a moment. Just have to do one thing here. Excuse me, just a moment, and I will get to you. Thank you. Great. There we go. Sorry, let me get to your case list while we are getting you unmuted for a moment. Let's see, Nina, if you can unmute yourself for a moment, I will go find your case list and we'll get going here. It's going to take a little bit of work to find it this evening. Oh, Nina, hi. Can you hear us okay?
Yeah, there's a sort button on the top right. I don't know if that gives you the option to alphabetize.
Well, let me see. Let me check here for a minute. Oh, there is. Hang on a second. It's being covered by one of my other. Let's see if we can do anything about that. Ooh, look at that. I think we're going to do this. So
yeah, I'm not there.
You know what? You are not. I'm not sure what to do that, but I'll be happy to chat with you about anything you'd like. In the meantime, though, is there just sort of a case that you've been looking at on your case list that you'd like to talk about, or a topic or anything? Pick up for a few minutes. Happy to do what you'd like.
Oh, sorry, I wasn't prepared for that. I was ready for an any case one.
Okay, I can do an any case one. That's okay.
So I can give you, I'm going to do my OB list. Sorry,
Sure,
I kind of want to finish that one.
Topic or a case, whatever you want.
I mean, they're pretty much bread and butter ones. They're not too crazy.
Okay. That's okay.
I had a patient, so she is 37. She's a G5P3. She came at 32 and 6. She had chronic hypertension. She came in an active labor, breech presentation, AMA, and obviously, and a fetal anomaly that was known at the time, and an additional one noticed postpartum. Complications, she had a placental abruption that was diagnosed at the time of the primary C-section. APGARs were 9 and 9, and the weight of the baby was 1360 grams.
Okay, sure. Any one of those topics that you'd like to discuss, or we'll just pick one at random and we'll kind of run with it for a minute?
Anything that stands out to you?
Okay, sure. So you said 32 weeks and hypertension, and she presented in preterm labor?
Yeah, she came in active labor. I believe she was 6 centimeters at 32 and 6.
Wow. Okay, great. So we can just, we could just start right there if you'd like to. Yeah.
Okay.
So a patient with known hypertension who presents at 32 to 33 weeks in active preterm labor, who I assume had not had preterm labor issues previously in the pregnancy?
No.
Yeah. In your practice, do you have do patients who have complications like hypertension seem more likely to you to have issues with risk for prematurity than patients who are without such problems?
Yes. These patients tend. Oh, I don't know if I should just say yes or give you more.
Nope. No, please go ahead.
Okay. Yes, for the simple reason that patients with hypertensive issues, they tend to manifest these issues commonly in the 3rd trimester and earlier than term. And because of those complications, they tend to require delivery.
Okay. In a patient with hypertension who presents in active preterm labor, what might you be thinking of as far as potential underlying factors that would have precipitated the preterm labor?
She could have had an uncontrolled hypertension. Knowing that there was a placental abruption diagnosed at the time of C-section, so at 2020 hindsight, that could have been the reason for the active labor.
How would uncontrolled hypertension lead to preterm labor?
No, but it could lead to the abruption that could have led to the labor.
Great. What other things might you think of in a hypertensive patient at 32 to 33 weeks, which might lead to preterm labor?
I'm sure I would know it if I wasn't on the spot.
That's okay. Are there any other complications of essential hypertension in pregnancy that could be linked to a high risk of preterm labor or preterm delivery?
Placental insufficiency.
Okay. Would placental insufficiency generally be an underlying cause of preterm labor?
It can be.
How would that happen? What about placental insufficiency might lead to preterm labor?
Well, that can lead to the abruption.
Okay.
I know I'm going down a hole right now.
No, you can. If you want to back up and turn around, you may do that if you like, because I'm not quite sure where we're going there, but that's okay.
I'm not sure either, and I'm not sure how to back up either. So.
Oh, you can say, I'm sorry, I may not be explaining myself well, and I'm not sure this is what I'm thinking. Could I start over again? Or could we back up? And that you can use any of those things. Just yeah, could I try something else? You can say any of those things, and the examiners will say sure. Yeah. What other complications might a patient with hypertension in pregnancy manifest, just in general?
So they can manifest with different effects on end organs. So this can manifest as cerebral issues, whether the patient is presenting with blurry vision or visual changes in general. This can affect the liver, where they may present with right upper quadrant pain, or they can also present with epigastric pain, which can also manifest as irregular obstetrical issues, GERD. Patient can also have issues with renal issues as well that could manifest as, in a baby as oliguria, or mom may have be impacted with her kidneys with proteinuria that may manifest.
Okay. If this patient came in when it was a known hypertensive and had blurry vision and or right upper quadrant pain, would that suggest anything to you in particular?
I would be, with a history of chronic hypertension, I would be concerned that she's having superimposed preeclampsia.
Is preeclampsia associated with an increased risk of preterm delivery?
Yes.
Yes. Okay, great. So when this patient came in, do you recall what was your appreciation of why she might be presenting a preterm labor before you got to the C-section?
Her blood pressures were elevated, but they were not severe. So I didn't think that this would even be necessarily hypertension alone can cause preterm labor, but I don't think that it was exacerbated to the point that it would be the cause of it. Advanced maternal age is a risk factor for preterm delivery alone.
True enough. That's a good point as well. Good. So then at the time of the cesarean section, when you identified that this was an abruption, I'm assuming you were looking at the hypertension. Upon performing the C-section and identifying the abruption, what would be your immediate concerns for the patient and management that you might set up or try to undertake?
With the abruption, because for her, this was most likely a concealed abruption. She was in active labor, but it was not to the point where it was exquisite tenderness, abdominal tenderness, out of proportion to labor, or concerning vaginal bleeding that way may have caused me to think that this was an abruption. So if it was a concealed abruption, I would be concerned about a more significant blood loss than what was initially seen from just a cesarean alone.
What might be the intraoperative complications of a patient who has an abruption in this situation?
For the patient, the patient may end up with a hemorrhage. hypotensive.
Mm-hmm.
For the mom alone, for baby, this could turn out to be, you didn't ask me that, so let's not go down that line.
Yeah, no, I agree. No, we'll talk about for the mom. So I'm talking, you're saying intrapartum hemorrhage, hypertension, which I'm assuming hypotension related to blood loss. Any other potential complications that we'd be concerned about in this situation? C-section, identifying a preterm abruption.
Besides hemorrhage, that hemorrhage could lead to worsening end organ damage of hyperperfusion to her kidneys, visceral organs, and this could lead to a sequelae of shock for this patient.
Okay. Right.
Anemia, hemorrhage.
So in that setting, let's make this our last question and then we'll move on. So with those things in mind, then how would you manage the rest of the cesarean delivery? Would you be making any preparations or sort of setting up any arrangements for any of those potential complications? And if so, how particularly would you manage the remainder of the C-section and the patient's immediate recovery period?
It would be dependent on the patient's vital signs. So I would be carefully monitoring her, excuse me, throughout the procedure and keeping in close contact with anesthesia to let me know how her vitals are doing. If she's normotensive, excuse me, not tachycardic, I would think that this patient is stable and may not be presenting for a potential postpartum hemorrhage or even intrapartum hemorrhage. Excuse me.
Good.
But if she is showing signs of worsening vitals or even stable blood pressure with tachycardia, I would be in my mind starting to plan for immediate labs as well as tocolytics to make sure that we control any potential bleeding, as well as putting blood on hold. I would, if she's tachycardia, I would consider starting to transfuse at least a unit or two to be ahead of a potential worsening hemorrhage. If she's, instead of making sure, instead of allowing us to be behind in the replacement.
Good. Just a moment ago, you mentioned control of bleeding. You said tocolytics. Did you mean uterotonics instead of tocolytics?
Yes.
Yes. Okay. That's fine. Sure. That's okay. Good. So if she had perfectly normal vital signs, the C-section wrapped up normally, but you had identified an abruption, what would your immediate postpartum surveillance in the PACU consist of? What would you be looking at and watching carefully?
I'd be monitoring her vital signs. I'd also be making sure that the nurse and I are in close communication with monitoring fundal checks to see how much, doing pad checks to see how much, monitoring essentially her vaginal bleeding so that, you know, it's not lost. It's not lost, and making sure that, of course, she would have a folian, so this wouldn't provide an obstruction. So if she's having any worsening bleeding, it would be evident.
Good. That sounds good. Is there anything else you'd be conducting surveillance for?
Could you rephrase the question for me?
Sure. So it sounds like you're concerned about issues with the abruption and risk of bleeding. You said you'd be watching her vital signs. Given her, her background history of the hypertension and how this turned up, is there anything else you'd be conducting surveillance for?
I've been monitoring her blood pressure with her history of chronic hypertension.
Very good. And would you be assessing anything other than her blood pressures? That's a good answer.
Besides her bleeding.
Related to the fact that she had hypertension, and now you've identified an abruption. She had preterm labor and had a C-section. Monitoring her blood pressures, I think, is a great idea. Why are you monitoring her blood pressures? Obviously, you're concerned about them being low. Are you concerned about anything else that might be going on?
Yes, because after chronic hypertensives, they can also tend to rebound and have worsening hypertension after acute trauma like a surgery. So she may have worsening hypertension, but it can also progress to preeclampsia. So I would be
there we go. Good. And as soon as that came out of your mouth, the examiner is going to flip to another case on the screen, and you'll be talking about PROM or something like that. Perfect.
Okay.
So this was where we're going here. We got everything out I think that we need to. It's good. Where I was sort of going, and it took just a little while to get to, is I was wondering what sort of hypertension, abruption, preterm labor. I was just sort of waiting for that this could be unrecognized preeclampsia or preterm atypical preeclampsia going on, which has a whole host of other issues associated with it, the intrapartum hemorrhage. I was waiting for DIC to come up. We did talk about appropriately transfusing and monitoring bleeding. I think a good pearl to remember is, as Dr. Shamroth keeps harping on, that the GYN portion of the exam is all about the ureter. The OB portion of the exam, no matter what, is always going to be about preeclampsia. So whatever you want to, if you just wait for them to ask you about the ureter and you do GYN case list, just wait for them to ask you about preeclampsia and just always feel free to bring it up because it's in the back of the examiner's mind. And in the recovery room, this was a hypertensive patient who had abruption. Really what I was waiting for when we got there was you're looking for vital signs, you're monitoring her bleeding. I would be saying, I'm checking her fundal height. I'm also asking the patient about any symptoms. I'm looking for, is this really a preeclampsia which might progress to severe preeclampsia? So I'd be doing symptom inventory for her. I'd be watching her vital signs very carefully. I'd be concerned about whether I needed to start IV magnesium sulfate post-operatively. Just throw stuff like that out there, and that would get you there very quickly.
Gotcha. I thought about all these things, but I'm like, okay, I'm not there yet, so I'm not going to say it.
No, you can be. The key, I think the good point about just talking about this case, which I thought was good, is just it is true. GYN, ureter. OB exam, preeclampsia. That's just, it's 100% like that.
Okay.
Good. No, Dina, thank you for doing that. You actually did a nice job. We got the information out. We practiced really nicely kind of how to navigate our way through exam when we're not sort of sure where the examiner is directing the questioning. And you did a nice job of that. You asked appropriate questions. You asked me to rephrase. You sort of decided to back up and move around. That's all really good, just learning how to navigate our way through an exam. I was pretty happy with that.
Awesome. Thank you so much.
Thank you. That was very nice. Thanks. Let's go back out for a moment. I think we're going to get to Dr. Durant next, maybe. Michelle, I'm going to get you unmuted here for a minute, and we're going to go see. I'm pretty sure we're good on here. We'll find your case list.
Okay, can you hear me?
Yes, I can. Hi, thanks for joining us. Got you, and I got your case list. That's working. Good. Where would you like to go? So we'll do talk about anything you'd like.
You can do anything.
Okay, let's see. Since we did OB, can we maybe pop down to GYN next?
Sounds good.
Round robin as we go through the evening. So your choice. Are there any particular topics or cases you've been studying recently that we should look at? Just topic of choice. Again, if not, I'll just pick out something.
I think you can just pick up something.
Okay, let's see. That's fine. Let's cruise on down here a little ways. Let's see. Just looking at all your categories here for just a moment. Got it. Okay. Let's cruise back up this way. Let's see. Good. I noticed here under laparoscopic hysterectomy, you got a, let's do this one, a 41-year-old gravida 4, her 4. And I noticed you did a TLH. The examiner's simple question would be probably, wouldn't this patient have been a great candidate for a TBH? And then they would probably go in another direction from there. In your mind, was this patient potentially a candidate for a TBH based on your preoperative assessment of her?
She could have been. I mean, she was multiparous.
Okay.
There was some descent during the exam.
That's fine.
However, in my practice, it is purely about the assistance that's available to me when I can do a hysterectomy. And this was actually a robotic laparoscopic hysterectomy. I just forgot to mention that part. So it purely is just what I can do safely for the patient, and that's why I chose that.
Sounds good. So if you said this patient had some degree of dissensus, if you were working her up, can you walk us through very quickly, how do you do a examination to assess pelvic support in the various compartments?
So in the examination preoperative consultation, I'll typically start with the pelvic exam, placing a speculum, just getting an overall assessment of the inside of the vagina. I can also remove half of the speculum and have the patient bear down just to get an assessment of kind of a pop Q essentially, to see if she has any prolapse, any signs of that. I'm not going to be able to get a full assessment of her descent, at least from a uterine perspective, until she's completely relaxed. So a little bit of that is uncovered in the operating room when she's asleep.
Sure. Yeah. Other than uterine descent or central vaginal wall prolapse. What other compartments of prolapse would you assess in this patient in the office?
I'm assuming you're referring to potentially a cystocele or a
Just the
rectocele.
general workup of assessing for pelvic prolapse. Sure. Yeah. What other compartments do you assess?
I suppose you could look at if the urethra is involved, but maybe.
Well, you mentioned cystocele. Are we going to go there next?
Yeah, there's cystocele, rectocele versus
right.
enterocele. Mm-hmm.
Okay. Cystocele, rectocele versus enterocele. Okay. How would you describe on your exam? How would you tell the difference between a rectocele and an enterocele?
Clinically, I could do a rectovaginal exam just to see for any kind of weakening. But if I'm being perfectly.
When you say weakening, what particular, does the examiners need to hear us talk anatomically, which is why I want to practice just talking this out for a minute. When you say weakening, what particular structures are you assessing when you do your rectovaginal exam?
It's, oh, you got me. Essentially just looking at that rectovaginal fascia. I can kind of see if there's thinning, if I can feel internally any defects or any kind of herniation with the bowel.
So is that rectocele or enterocele that you're talking about there?
That would be an enterocele if there's actual bowel prolapsing through the gap. If it's just a weakening, then that would be more of a rectocele.
Okay. I'm going to ask you a little bit more because I'm trying to visualize this. So can you tell me how if I was standing behind you watching you do your exam, how do you tell the difference between an enterocele and a rectocele? You said if there's a weakening of the fascia, that's a rectocele, and if there's bowel prolapsing through it, it's an enterocele?
My understanding, I will be honest, I'm not the greatest at assessing that. I would imagine also you could tell surgically when you are looking at bowel.
Okay, but in the office, we have to do this in the office. So in the office, do a rectocele and an enterocele occur at the same site or in the same location?
A rectocele can be more, I guess, distal, closer to the like the sphincter muscles. I assumed the enterocele would be higher up.
Yes, exactly. So could you tell me what structure separates the rectocele from the enterocele? So you're saying a rectocele is lower when you're doing a rectovaginal exam and an enterocele is higher?
Mm-hmm.
That's correct. Good. So again, so when you're going up and doing the exam and you're sort of feeling for a defect, at what point do you say, okay, this has got to be an enterocele rather than a rectocele? As you're working your way inward on the rectal exam and you're going up the rectovaginal septum.
Purely speculating, I would say, that the internal sphincter, I'm going to say, if it's higher or lower.
The internal sphincter is at the anal verge. Where is the enterocele at the anal verge, or is it?
I will be honest, I don't know. I'm going to say I would have to look it up.
Okay, no, this is important because this is one of those things we actually really do have to need to know to get through the exam. So if you were putting in a speculum, like a big wide speculum, opening it up and looking in there, would you be able to see an enterocele if it were present? I think you would. Can you tell me where you'd see the enterocele relative to the cervix and the anterior fornix and the lateral fornices and the posterior fornix? Where would the enterocele be?
I would expect it more in the fornice versus
anterior, lateral, or posterior fornix.
Okay.
Which one? Anterior, lateral, or posterior fornix?
I am not sure.
Well, it should be posterior. It actually should be below the cervix. It's actually the culdosac. So when you're putting in our laparoscope, we're doing abdominal, when you look behind the cervix, the rectum, that goes in the sigmoid and becomes the rectum. And then there's the cervix, and right in there is the posterior culdosac, and the prolapse of the culdosac is the enterocele. Now, the rectocele, you were trying to get this right, and you said it was the fascia between the rectum and the vagina, which is the rectovaginal septum. You can use that term too. So a question, we have to be able to describe this to the examiner. At what point does a rectocele stop and an enterocele start? And that is at the top of the rectovaginal septum, because the rectovaginal septum is the rectum and the vagina are sort of stuck together and opposed by this muscular layer that has the septum. And when you get to the top of that, then you are into the culdosac, and now there's the peritoneal cavity. There's no longer a rectovaginal septum. That is where sort of the pararectal tissues fall away to the back, and the paracervical ligaments in the cervix are up to the front, and it opens into the culdosac. So I would like you to practice this when you do your in the office tomorrow, the next day, doing your exams, you're doing a rectal exam. Go and find this. You want to put your finger all the way up, go up to the top of the rectal vaginal septum, and you'll feel a V at the top there where you can actually hook your finger over a little bit, and you're coming out into the culdosac. And if your finger were really very long, you could hook your finger around and come back down behind the cervix into the vagina through that culdosac, just pressing on the culdosac there, and you'd be sort of pushing or creating an enterocele. So rectocele is between the rectum and the vagina in the rectovaginal septum, which should go up about 6 centimeters, 7 centimeters or so. And beyond that, at the top of the rectovaginal septum is where the culdosac is. And there's sort of a V where the septum just dissipates. And that's the enterocele, which if you were doing a speculum and putting in there, you see a bulge behind the cervix, which is a culdosac prolapsing into the vagina. If you wanted to examine for a rectocele, you might do that bivalve speculum, but use only the anterior blade, and you'd see sort of a protrusion of the rectum all along the posterior vault into the vagina, which is the weakening of the rectovaginal septum, and it sort of humps up there. Does that make sense?
Yeah.
Is that something that you can kind of see? I would look at that in an atlas of pelvic surgery. I want to just, when we start talking about it, I thought we probably should get there, because that's something that often we have difficulty describing, but we have to be able to sort of identify, for a cystocele, you could describe for me where a cystocele is easily, and you can describe central prolapse. But the difference between a rectocele and an enterocele is really hard to describe in the exam. And it's important to practice it because I think it's a favorite examiner question. And it involves sort of our understanding of the anatomy up there, which I think we got out. So rectovaginal septum all the way up between the rectum and the vagina. If you think about how you do rectocele repair, you would size up the posterior vagina, you get down to that fascia, which is rectovaginal septum, and you plicate it together, right? If we do an enterocele repair, what are we doing? We're actually going above the rectovaginal septum into the culdosac, and you're doing like a, we'll call this caldoplasty or Moskowitz. It's not very useful, but you're sort of acunculate, you enter the culdosac with an incision behind the cervix. So that's a posterior colpotomy. Now you're in the peritoneal cavity, totally different from rectocele repair. And then you do the repair that way. Does that help to kind of clarify it?
Yeah, that does. It's something I had never really thought about, so I appreciate that.
Good. No, that is something we all need to practice, because in the exam, they sometimes will throw up a little diagram and ask us to show them where the enterocele is and rectocele is, but quite often they'll ask us to describe it, and we can really get stuck if we haven't practiced that once or twice beforehand. So, Michelle, thank you for letting us go through that. I think that was one of the more important things we're going to do this week. And all of us, please, all of us, when we go into the office in the next few days on their rectal exams, go practice that. Work your way all the way up top of the rectovaginal exam. Kind of find that V at the tip of your index finger. You can sort of feel that that's the peritoneal cavity right up there, and that is where your enterocele lives if you have a weakening or a prolapse. And once you do that once or twice, you'll be locked in, and in your exam, you will just be able to describe it with your eyes closed. Once you feel it, you'll be good. Great. All right, thank you, Michelle. Thank you very much. That was very useful. Thanks. Let's go back for a minute. Okay, so we need to move on and get some more of our candidates here. Let's see. Dr. Shibata, Renee, can I come to you in just a moment? I'm going to go find your case list for a moment. Right here, got it. Good. Let's see. Renee, if you can unmute yourself for a moment. I have your case list up here, and I'm ready to go with you if you'd like.
Hi.
There you go. Hi. Hi. Can you hear us okay?
Yes, I can.
Good. Thanks for joining us. All right, your choice, OB/GYN or office, what would you like to do?
Can we do OB, because I don't do that often?
Yeah, sure, of course. Happy to do that. Any particular topic or sort of case
Anything
on
is
OB?
fine.
Anything. All right.
No, OB help.
No, that's okay. Let's see. All right, let's see. Go something different here. Let's see. Let's see. We'll get off the preeclampsia stuff for a little bit. Let's see. Okay, can we look at, I'm just going to ask you, in the past couple nights or so, have we done anything on TOLAC and VBAC? To your knowledge?
I don't believe so. No, to my
Okay.
knowledge, no.
Okay, that's fine. Let's do case number 15 here for Renee, 33-year-old gravid, 5'2", 39 weeks. It says just labor and apparently no other issues in her pregnancy, except that one of the things you do need to mention to the examiner is that she's had one or more prior cesareans. Do you recall how many prior cesareans she has had?
She had one prior cesarean delivery.
One for that. Good. Okay. And do you recall the indication for the cesarean in that first case?
It sounded more like maternal request.
Okay.
She was an induction. She didn't remember why, but she was an induction, and she was in labor, induced for less than 24 hours, but had requested a cesarean delivery after being 4 centimeters for several hours.
Got it. Good. So with that particular information, how would you counsel your patient about the idea of attempting TOLAC in this pregnancy? Based on what information she gave you, what would you discuss with her as far as the potential benefits versus risk of TOLAC in her particular case?
Okay. The potential benefits, speaking from a maternal standpoint, is a VBAC or vaginal birth after cesarean delivery would allow her to have a vaginal birth and not have a repeat cesarean delivery or surgery, which would lead to a faster recovery time. That would be a benefit. The other benefit would be, though there's no increased necessary risk for the fetus for cesarean delivery, the trial of labor can lead to less need for respiratory support at the time of delivery.
Okay.
Those are kind of the benefits, mostly focusing on not needing a repeat surgery. And speaking to her, that was something that she wanted to avoid because she said she had a difficult recovery. The risks for a trial of labor would be potentially needing a cesarean delivery, either for either maternal request again or for fetal reasons. I also counseled her that
for just a moment, you said the risk of needing a repeat cesarean delivery would be by maternal request or for fetal reasons. With a given her history, might there be any other reason why she might end up with a cesarean delivery in this case?
She did not meet the definition of a failed induction.
That's true.
But because she did report a history of not being able to dilate past 4 centimeters, there's always the chance that she may not progress.
So it just so you can put it in clear terms. So when we're thinking about other reasons why she might end up with a cesarean section in this case, how would you phrase that particular risk? What situation might arise for which she might need a C-section?
She may have failure to progress.
Sure. Okay, sure. Yeah, failure. Yeah, first stage arrestive labor, failure to progress. Sure. Yeah, I think that would be it. So because you mentioned just maternal request and fetal issues, but we're thinking about labor dystocias along it here, because I kind of wonder about that. I mean, she went on, it sounds like for a while, she didn't dilate for a while. If she had gone on longer, might she have been diagnosed with an arrest? Could there be a risk of recurrence? Of course, there always is an increase in this pregnancy, in this as well. Aside from first stage arrest or failure to progress, is there any other situation that might arise that maybe she's a little bit higher risk for based on her previous care for which she might end up with a cesarean delivery? Other than what you've mentioned, which is maternal request, first stage arrestive labor, or fetal issues?
Not that I know of.
Okay, well, you said she didn't meet the criteria for failed induction of labor in her last pregnancy. Is it possible that in this pregnancy she might actually end up meeting the criteria?
She may, yes.
She may, right. So that's another thing. So when we're going down, this is really the examiner's just opening up, and the examiner just wants to listen to hear you just list all the reasons why this woman might end up with a C-section. We can go through a bunch of them. It might be prolonged induction with maternal request. It might be failed induction. It might be first stage arrest or failure to progress. Maybe she actually would get all the way and she'd have a second stage arrested labor. Maybe you should develop chorioamnionitis during labor with a category 2 or 3 fetal heart rate tracing. Then there are the fetal issues that we talk about. And then you can throw out anything else in there in this pregnancy. Maybe there actually might be a compound presentation or a malpresentation of some sort. The examiner's just interested for you to throw stuff out. And I think it's easier to start with what you sort of described this patient in a way that maybe sound like, maybe if she had not opted out to a C-section further, she might at some point though have qualified based on medical indication for another reason, like dystocia of labor or something like that. And we can start there and then sort of, and branch out from there. So based on what you know about this patient, and you're right, she didn't meet criteria, how would you assess her likelihood that she might have a successful VBAC in this pregnancy?
The likelihood of success, one of the things that was favorable for her, she came in labor.
Yes.
She was in early latent labor, not active labor, but she was she was like 4.5 centimeters dilated.
Right.
So that was past the original dilation of her first cesarean delivery. She is also was not obese.
Good.
She was also under the age of 35.
Yeah.
She had she reported no antepartum complications, no issues with gestational diabetes, hypertension, or anything like that.
Good. So if you were talking with her, if this was a patient who had no what we call recurrent risk, sort of, which would need a C-section, like a labor dystocia or something like that, what rough percentage would you give her as far as likelihood that she could have a successful VBAC? This is their approximate percentage that you would give her if she asked you.
I would have to reconsult my resources, but it's roughly 30. I'm not going to guess.
That's fine. If she was someone who actually in the last pregnancy had sort of qualified as a first stage arrested labor or a failed induction, is there a rough percentage that you would quote for her as far as the likelihood that she might have a successful VBAC?
About over 60%.
Yeah, I think in the 60s, 60, 65 is something that's in the practice bulletin. For someone with no recurrence risk, I think maybe 75, 80, something like that. And the important thing is that there is a spread. We're talking about maybe a 15% up to 20% difference there, which can be significant. That means 1 out of every 5 women. So I think knowing those statistics is useful. But I think what the examiner is just asking is sort of, how do you appreciate this patient's, if you tried to give her a reasonable, reliable estimate, it's just an estimate of risk, would you lean more towards sort of that she did have a prolonged labor and she opted out for a C-section before maybe she might have declared herself, or would you lean toward sort of the stuff that suggested she may be a really favorable candidate for labor? And they're just asking you to kind of go where you want to go with that, how you would discuss it with the patient. I think sort of conservative balanced mode of practice is I would want to go right down the middle. And if I were doing this in the exam, I would say, well, she came in labor, she was more than 4 centimeters like she was before, she was not obese, she had a lot of good stuff going for her a C-section. That puts her in the 80% category. But I really wonder about that prolonged labor in the last pregnancy, and maybe she could actually, this is a different baby, different size, maybe she had a labor dystocia. That would put her in the 60%. And then you're telling the examiner, the stats. So I would have to tell her that maybe she has some good outcome criteria. And the stuff they have in the last pregnancy may get in the way of that. So maybe she'd be put over the middle. Maybe I'd fall around 70% or something like that. You can manage that any way you'd like, but I think what the examiner is asking is just to sort of strike a balance in there.
Okay.
And that would be fine. And in this case, despite a category 2 fetal heart rate testing, she had a VBAC, which is really great.
She did.
Good work. So it sounds like well managed. All right, Renee, since we've got just a couple minutes or so, is there anything else about the way we went about this case that we should talk about or that you'd like to ask about? I'll be happy to go further with anything you'd like about that.
So I forgot to.
Yeah, go ahead.
I'm sorry. I forgot to mention in this case, she did get Pitocin at the very end. If you accidentally forget to put some sort of so I would imagine that would be kind of important that I would have wanted added. Is it appropriate to mention it, or is it one of those things that once it's in, it's final? Okay.
No, always, no, always, no. Oh, you always want to amplify whatever's important in the case. So in this case, one thing is you've got this VBAC, but it doesn't even say that she has a previous C-section. First thing I'd want to be sure the examiner knows is that I know the criteria and contraindications for a TOLAC. So I'm going to say, now this patient had a cesarean delivery, which was documented as low segment transfers at term, and then briefly describe sort of the course of her labor, as you did very nice. Let them know that it wasn't classical or something like that. And then you can move on from then. The examiner may just stop you and say, well, tell me what other things might be contraindications to TOLAC, and talk about that for a minute. Or you can say, in this case, your labor required some augmentation at the end of the pregnancy, and the examiner may want to ask you sort of, in your practice, do you induce or augment your patients under TOLAC? What are particular considerations in there? How do you decide when and when not to do that? And that might be a discussion. So each one of those things that you bring up is sort of an avenue to have a conversation go in a different direction.
Okay, thank you so much.
Good, thank you. Nicely done. Let's go right back over here for a moment. Dr. Zafra, Rita, you had your hand raised just under Renee there. You happen to just be below her on my list. So if you would like to participate, please just pop the raise your hand button up there. But for a minute, I'm going to go ahead right away and get one of our other candidates. So, oh, thank you. There she is. Good, Rita, thank you. Let me get you unmuted, and your case list is right up here by alphabetization. So I got you. Hey, there you go. Thanks for joining us.
Good evening. How are you?
I'm doing great. Thank you. Thanks for joining us this evening. So I'm all ready to go here. OBGYN or office, I think you get to choose.
Can we do OB, please?
Sure, of course.
Yes,
Go
thank you.
Let's just kind of cruise briefly through your OB cases. So we got about 37 cases. Good. Any particular topic or case type that you'd like us to look at? You absolutely may choose.
No, I think I did before. I think any case at the beginning can be good. Yeah.
The beginning. Okay. Let's see what we got going on here. Let's see. We talked about hypertension. We got preterm delivery there. Let's see.
In the first 2-3 pages, yeah.
Okay, 2 or 3 pages. Okay, sure. Let's see. Okay. Let's see. Great. Let's see. Can we do case number 3? This will make this maybe kind of a shorter discussion. Yeah. So early term delivery, we've got someone who said 38 weeks. And she comes in, she's got nothing going on. She had a vaginal delivery. It looks like the easiest case in the world. If this patient she turned up in labor at 38 weeks and 5 days, and you were the doctor taking care of you, and you went back in her prenatal record and you identified that she'd never had a group B strep culture or assessment attained, and you asked the patient, and to her knowledge, she had never actually been tested for group B strep colonization in this pregnancy, how would you determine whether she might need GBS prophylaxis in this labor or whether maybe she wouldn't?
Okay, so she never had the GBS before?
Let's assume that this patient, as far as we can tell, is 38 weeks and she never had GBS assessment at any time in her pregnancy. So knows nothing about it, and there's no record of it whatsoever. How would you go about determining, is it possible that she might need GBS prophylaxis? I mean, she is actually 38 and a half weeks.
Yeah, so I will go by the history, a history of prior pregnancy with GBS positive. I offered, it will be a shared making decision, and the other reason will be the patient has prolonged rupture of membrane, more than 18 hours also, and GBS unknown. And the other reason can be has positive urine culture for GBS, or prior baby with a GBS infection.
Good. That sounds good. So let's see. So going in this pregnancy, you said if she had membranes ruptured more than 18 hours, and unknown to it, we would do that. Regarding sort of what's going on right now when she comes in labor, is there anything other than the rupture of membranes for 18 hours that might be a flag for her to get GBS prophylaxis?
If I do a rapid GBS.
Sure. Good. Very good. Yeah. Any other findings on maybe her admission evaluation or her labor course for which maybe she should get GBS prophylaxis?
Admission.
Or during labor. So rupture membranes greater than 18 hours.
Fever.
Fever. Very fever. Good. And if you did a rapid test and it was positive, then the other thing I like that you mentioned, this is very good, is you're going back in the record. Is there anything else on her OB record that suggests GBS positive, anything other than a culture? So right, urine assessments. Did she have any urine assessment anytime during pregnancy which happened to flag GBS positive? And then you mentioned the previous pregnancy, and that was the thing I was really interested in. So in the previous pregnancy, you said if she had an infant who was affected with invasive GBS disease or had a bad outcome due to GBS. And then you said something else about the previous pregnancy?
Yeah, if the patient was positive for GBS in the past.
Right, very good, good. So none of the other criteria about the fever, ruptured membranes, stuff like that applies. She's unknown GBS, but if she was GBS positive in the previous pregnancy, that by itself is an independent criterion. Very good. So if the patient has no recollection whatsoever about her previous pregnancy and GBS and just doesn't remember it, and she's not ruptured membranes, and she's not febrile, and nothing in her record in this pregnancy suggests that she has a GBS positive result, but she just doesn't remember anything about the last pregnancy. How would you determine whether or not to give her a GBS prophylaxis?
So I will do the rapid, no? The rapid GBS.
Okay, sure. Let's do the rapid there. Just do the rapid. Okay, so in that case, you're going to go to the rapid test. And if the rapid test is negative, we're not going to give it to her?
If
the test is positive, we aren't going to give it to her.
Yes.
Good. Okay. If a rapid test is positive, what antibiotic would you administer to her?
The recommendation is penicillin for GBS. I will give her 5 millions, like the loading doses, and then 2.5 every 4 hours until delivery.
Good. Good. Is there anything else you'd want to know from her before you administer the penicillin? You said they're doing the penicillin, G?
Yes, I will have allergies and to see if she's allergic. Also, if she, allergy.
Okay. If she has penicillin alert, she says, yeah, it was when I was a kid, I had penicillin and they took me to the hospital and they told me I almost died. How would you manage that?
Well, I will when I collect the sample for GBS, I will send that for susceptibility to see if it's susceptible to clindamycin.
Good. How long does it take in your hospital to get a rapid result back on a GBS?
Usually, we don't have actually the GBS rapid, but usually I heard that it's about 3-4 hours.
Okay. How long would it take to get the sensitivities back, do you think?
The sensitivities back almost maybe a little longer.
It would take a good bit longer. Yeah. So the important thing, I think, if I were discussing this case, and this is just a way of helping ourselves out in the exam, if you don't have the rapid GBS in your hospital, what I would say is, I understand that a rapid GBS would actually really help us in determining whether to administer to this patient or not. However, in my institution, I don't have that available to me. Okay. And you can just, then that takes it off the table, because then they're not going to ask you niggling stuff about the what you can get from it, like I am right now. They would just go to what other antibiotic would you give her? So if she had a penicillin allergy and we couldn't get, you could get a GBS positive, but you couldn't get the sensitivities, or if you just couldn't do a rapid, we're coming back to the same question. How would you decide whether to give her a GBS prophylaxis or not? So now they're just putting you in a tough position because you just have no information to go on. But this can happen sometimes.
Yeah, so no information at all, and the decision, well, if after a history and evaluating risk factors, and there is none of the risk factors, and I will not do GBS prophylaxis.
Okay. And certainly, I'm assuming if she'd had a baby affected with GBS disease in a previous pregnancy, she would remember that and she would tell you. But the issue is she might have been GBS colonized in a previous pregnancy, which is an indication for doing it now, because that means she's at increased risk of being colonized now, but you can't get a rapid GBS. So the examiner is going to say, so really you wouldn't give her GBS prophylaxis? Because maybe she was colonized in the previous pregnancy, she doesn't remember, but isn't that now a risk factor for her needing GBS prophylaxis now?
Yeah, but it will be, I will present that information to the patient and, and yeah, I will present the information to the patient, and I said I evaluate her risk factors. I don't find anything, but there is a possibility that in the past maybe she was GBS. I don't sure, and given that in situation, I will it will be up to the patient. But
would you recommend one way or the other to the patient?
well, I will recommend that after evaluating her risk factors, and I don't find any indication for GBS. Therefore, I don't have her information on her past medical records, and she does not have, and there is no any way to get her information. At this point, I will, my recommendation was just be not to give her GBS, but my obligation is to inform the patient and make sure that she knows that.
Okay, we're in a tricky place here, and the exam, I think we should be very careful. We want to be conservative in our mode of practice. The general rule is for a term pregnancy, we don't give GBS prophylaxis if the status is unknown in this pregnancy, except in those particular circumstances. And some of them you can assess immediately. You can tell if she's been ruptured more than 18 hours. You can tell if she's febrile. You can't tell the stuff about the previous pregnancy, and that's listed. That's equally weighted on the list of risk factors with ruptured membranes 18 hours, febrile, previous infant with GBS disease, or colonization in a previous factor. In fact, and if you don't know one of those, the question is, the examiner says, well, if she was colonized in the previous pregnancy, doesn't that make it more likely that she's colonized now, even though you don't know it?
Yeah.
They'll put you a little bit on that. And in that instance, because if you read the practice bulletin, those factors are all weighted equally. The ruptured membranes, the febrile, the previous infant with GBS disease, and the colonized in a previous pregnancy, but no result in this pregnancy. I might lean a little bit towards saying I would counsel the patient, that we don't know. But I mean, let's take the penicillin analogy off the patient. She can take all the penicillin she wants to. Balancing risk versus benefits, might it not be better to err on the side of caution and give her GBS prophylaxis for an unidentified risk factor?
Okay.
And might that be, rather than have an infant that actually is exposed to GBS because we didn't? And that's balancing the risk that the patient would be one of the 1% that has a penicillin allergy to this particular penicillin, which would be low, against the risk that we might have a baby that is actually GBS colonized and the baby would be exposed. And then what's the percentage chance that the baby could be severely affected? I would describe it to the examiners that way. I think they want to hear that we're thinking about risk versus benefits. And I'm not sure I would come right down on no. I would come down on maybe to possibly yes, after discussing with the patient that there is a risk of administering to her penicillin and she might have an allergic reaction. I think it might be better to cover that unknown risk factor, because when you go down the list of risk factors for whether you should give her GBS, you can identify the 3 of them don't exist, but you can't identify that the 4th doesn't exist. Does that make sense?
Yeah, it makes sense.
Well, they set you up. This is what they do in the exam. They set you up in a position where there's a dilemma. And we have to sort of think our way through an unfamiliar situation. And what we should do is step back and just go through the risk factors and sort of figure out what do we do with a risk factor that we can't actually resolve one way or the other. And is that maybe worth giving her an antibiotic, which is very, very low risk for her, versus having a baby that could be exposed to GBS and could potentially have a serious sequela of that. I think that's the way we might want to think about it.
Yeah, okay, sounds good.
All right, good. Thank you, Zara. Another really good discussion. Thank you for doing that. Let's cruise on along here for a moment. Let's see, now we're going to go to, let's see, there was Dr. Steele had her hand raised to do a case, and also Dr. Carvalho. Let's get to Erica. Erica, oh good, you're unmuted. Let me just run right down and get your case list. Can you hear us okay? Erica. Erica, are you there? I've got you unmuted. Dr. Carvalho. She's not answering, so we'll come back to Erica. We'll come back to you in just a little bit. We'll see if we can find another one here. Looks like Matthew, Dr. Four has his hand raised. Matthew, we'll go to you. Let me just pull yours up. We'll come back to Erica in a minute. There we go. Matthew, got you right there. Matthew, I think we got you unmuted. Can you hear us okay?
Yes.
Oh, good. Thanks. Good. Thanks for joining us. All right, I am ready. Where would you like to go on your case list?
Let's gyne. Gyne sounds good.
Sure. Gyne sounds good. All righty. Right. Any particular topic or sort of issue in that you've been studying here that you'd like to look at this evening?
Nothing in particular, I guess. I've already done chronic pelvic pain recently,
Sure.
so
Yeah,
that
no,
one.
we'll steer clear of that. That's fine. Let's see. Let me see. Let's see. Let's cruise down here. We'll kind of see what sort of stuff we got. We'll find something. There's nothing there. Let's see. Can we may do something with maybe case number 33? This is under your incomplete septic, complete other abortions, maybe for a minute.
Sure.
Let's see. So 36-year-old, there go 6 pair 5. So completed with complected incomplete SAB. And just looks like something within the endometrial cavity, but she did have declining titers, and she elected to go to a suction DNC. So we had hypersecretory endometrium, no chorionic villi identified in the specimen. So it looks like possible incomplete SAB. Ultrasound suggested retained products. She did have declining but positive titers. She declined everything but a suction DNC, but we didn't get chorionic villi on the DNC. So the examiner might say, so in this case, how will you continue to manage this patient? It sounds like the suspected incomplete AB, we're not sure whether that was so or not. The whatever it was in the endometrial cavity, apparently we didn't find. How would you continue to manage this patient after the DNC and after reviewing the pathology report with her?
Sure. So this was actually, it's an interesting timeline of events for her, actually. So she had a transvaginal ultrasound that showed an intrauterine cystic structure, as it mentions on there, concerning for possible retained products versus incomplete AB. So she actually went to the ED, had that ultrasound read, and then came to me in the office, at which point I discussed her options of medical, expectant, or surgical management. She had significant bleeding over the last several weeks and had not had complete passage of tissue from what she had noticed, continued bleeding. And her HCG levels had been declining, but they hadn't, it hadn't shown complete resolution of the pregnancy. So after discussion of those 3 options, she elected for surgical management, which was scheduled in the outpatient setting, given that she hadn't had, it wasn't an emergent case, or she wasn't having significant anemia, signs or symptoms of anemia. So during the interim between the preoperative appointment and her scheduled surgery date, actually I think the night, maybe about 18 hours before her time to presentation to pre-op, she had a large passage of clot in what she thought was tissue. And we actually discussed in the pre-op bay, repeating the ultrasound to see if there were any contents left, or that intrauterine cystic structure had resolved on its own. She declined due to personal reasons and her continued bleeding. She wanted rapid resolution to make sure that there was no retained tissue, given that she had had weeks prior of bleeding with possible retained tissue. So we proceeded with the DNC, understanding that there could be a complete resolution of the miscarriage prior to the suction DNC, and of course her pathology noted that. We also mentioned the fact that it could be an extrauterine pregnancy, although it was unlikely given that the ultrasound was negative, and her HCG levels were declining substantially. I did recommend continuing to follow her HCG levels weekly, but she was unfortunately lost to follow-up, given her significant personal issues, and I only touched base with her about 6 months after the procedure. So yeah.
Good. So had you had the opportunity to continue postoperative care, what would that have consisted of in this case?
That would have consisted of weekly HCG, beta HCG levels until they were confirmed to be 0.
Good. If her HCG levels over the first few weeks or so seem to be roughly at a plateau and we're not moving up or down. What would be your considerations there? What might explain something like that happening, given the history you've very nicely laid out for us here as far as what's happened so far?
Given that the pathology showed no chorionic villi and the plateauing quantitative HCG levels present over the several weeks postoperatively, I would be concerned for an ectopic pregnancy.
Okay. Is there any other possibility here? That's one, definitely.
She could have like heterophilic antibodies are possible. Which could...
Okay, I mean, we'll never fault you for putting that out there. That we can definitely go with that too. Yeah. Anything else?
Let's see, ectopic,
either plateauing or declining slowly, maybe.
There could be concern for like gestational trophoblastic disease. But
okay, sure. No, that's a good. I was wondering if that would come up because so far we don't have any tissue diagnosis for her regarding the status of this pregnancy. I would definitely put that in there. Yes, absolutely. We'll come back to that in a minute. Anything else? We've got 3 good things out there. 2 plus heterophil antibody, which is less likely, but I still like that you mentioned that.
Okay. It could have been that I didn't get the proper amount of tissue, and she could have retained.
Right, she still could have retained products. Now, this was, I think you had a reasonable ultrasound. I'm assuming this was sort of a normal uterine cavity. In one of our previous sessions, we talked about the possibility we have to consider congenital uterine anomalies like a septate uterus or something like that. Let's assume, because we already talked about that this is actually a single uterine cavity. It's not duplicated or significantly septate. What sorts of things might have prevented us from getting to where the tissue was so that we could remove it if she has actually a unitary rather than a duplicated uterine cavity?
And
this is the examiners are throwing out out there just to get us to brainstorm and sort of think outside the box a little bit.
Sure, it would. There's a possibility of like a arcuate uterus or bicornuate uterus.
Okay, sure. We said it's. Let's say it's not bicornuate. Arcuate. Yeah. What arcuate? What does arcuate suggest to you? Why might that interfere with us having gotten the tissue?
Because it could be that the cannula only went into one sort of area of the bifurcation rather than both.
Arcuate is a little bit of a heart-shaped uterus, and we might not have tucked into that corner. Maybe it was hiding up there in the cornua somewhere. That's a good one. What else might be going on within the uterine cavity? Maybe if it is a single uterine cavity, which could have interfered with us getting to where the tissue was. Anyway, what we're thinking about here is anything that's if it's not a bicornuate or septic uterus, anything irregular about the cavity which could interfere with us maneuvering around inside the cavity. So aside from arcuate uterus, what other things might we think of? Just random, just other reasons why the inside of the uterus might be in some way irregular.
I guess the only thing I can think of if it's severely retroverted or antiflexed and we weren't able to end all the way to the fundus.
Let's say it's in the middle. I'm thinking about the inside, the contour of the endometrial cavity. What else might cause an irregular contour of the endometrial cavity other than a congenital malformation?
Fibroids or polyps.
Fibroids, intercavitary or significant submucous myoma. Yes, that's what the examiner is waiting for. Good. So the next question is, her titers are plateauing or slowly declining. You don't see any adnexal mass on examination. We haven't gotten tissue. What would you do next? Might you be your next step, given what you've described to me as now your considerations? What might be your next step in evaluating this and trying to resolve the situation?
Well, I mean, when I would see her back in clinic, the easiest thing to rule out heterophilic, the zebra of heterophilic antibodies would be to get urine pregnancy tests. So that would be
good. Okay, good.
Easy.
Got that done. Good.
And then as far as I'm trying to think for ectopic pregnancy, obviously we could always repeat the transvaginal ultrasound, potentially seeing if there's anything, but if a declining HCG would likely mean that we wouldn't be able to see anything either on ultrasound if we didn't see anything to begin with.
Yeah, probably.
I would possibly also get if I was concerned about gestational trophoblastic disease, I would consider getting a chest X-ray, TS, those kinds of things for the workup of a GTD.
Yep, that sounds good.
And then,
so the one remaining thing is the products are inside the cavity and we just haven't gotten to it yet. How would we work around to that?
We could do a hysteroscopy.
There you go. Sounds great. Good. Yeah. So of those things that you mentioned to me, what would you most likely do first?
The low-hanging fruit would, of course, be the urine HCG, just to rule out.
Okay, sure. Okay, well, we'll check that box off. And the urine is negative. What would you do next? Yeah.
Then I would likely get a transvaginal ultrasound.
Okay.
Just assess if there are any myomas that might have been missed on the initial ultrasound or other anomalies that could have interfered with obtaining proper tissue, or see if there's thickened endometrial stripe with hypervascularity. And then I would likely set her up for hysteroscopy DNC.
Perfect. Good. When the examiner's looking at this case, and I'm sort of looking at it as you're reading, I'm wondering about over here, this intrauterine cystic structure. Was that actually like a degenerating intracavitary or submucous myoma? And if we do repeat the ultrasound, is that still there or is it not there? And if so, I think we're doing a hysteroscopy to go find out what it is, whether it represents our retained tissue or whether it represents an obstruction for which we couldn't get to the retained tissue. And the hysteroscopy would sort of allow us to identify where the tissue is. I think that's perfectly described. So I like ultrasound first prior to hysteroscopy, but then going right into a hysteroscopy. I think that's absolutely reasonable. Good. Okay. Matthew, that was a nice discussion. That was actually, you worked your way through that very nicely. Thank you. And let's take a minute. Is there anything you'd like to ask about that, or just anything else that we should talk about on this particular topic?
I guess for similar cases, going to the more extreme, because I've heard this in previous sessions where you do a DNC for an incomplete AB, it comes back, no chorionic villi identified. Yeah. You had a fairly certain that you were able to obtain a good sample of your specimen, and then you have concern and you continue to trend the quants, concern for ectopic pregnancy. At what point would you say it would be reasonable to say I have concern for an ectopic pregnancy and would offer the patient methotrexate?
Good. And I think we might have talked about this before when we talked about the bicornuate uterus example. But the reason we got into this is I think we had a suspected incomplete AB. So somewhere there might be an ultrasound that indicates that there really was a pregnancy in the uterus. Now I would try to go back to define that. And if so, then we're not thinking about an ectopic pregnancy. The only thing could be a heterotopic pregnancy, and we're still dealing with something in the uterus. If we don't have that and she just shows up and it's like possibly retained products, then you're right, we're not sure. So I think the point at which it's still statistically much more likely that this is in the uterus than out of the uterus, just given the statistical likelihood of an ectopic. I would go through the repeat ultrasound. I would go through the hysteroscopy. I would do directed sampling under hysteroscopy. And if I still got nothing, now I think we're pregnancy of unknown location and maybe ectopic pregnancy. I think there's maybe the time, do you think, to offer her methotrexate?
Okay.
After you've really scoped the endometrial cavity, you've checked out everything and there's nothing in there and you do more sampling, it's still not there. Now we don't know where. Now I think it's pregnancy of unknown location.
Okay, great. Thank you.
I think that's where we go. Good. Matthew, thank you. That was nicely done. I think Dr. Carballo, Erica, I want to try you again. You're unmuted, Erica. Can you hear us?
Yes, sorry.
Oh,
I
good. Thank you.
went on a work desktop without thinking that I wouldn't be able to communicate.
Nope, glad you're here. All right, so let's get down to your cases, then we'll come to Dr. Castillo, I think, in just a moment. Oh, there you are. Good. Get you up here. All right, you get to pick anything you'd like to talk about.
Can we do OB?
Yeah, sure. Yep. Just a second. Sure. And office practice is highly unpopular this evening. All right, there we go. All right, OB, got it. You could pick any particular topic or problem, category, or case that you'd like to look at.
One thing I just wanted your take on is this ended up coming up as my first case on here, where I just didn't put a lot of actual management things that were done in this person's antepartum admission, like magnesium and steroids. Yeah, that might have been a little negligent on how I listed
No.
that one. And
No,
I
is that
forgot
okay?
steroids on one other part. So I just wanted
Okay.
to ask how to
Yeah.
manage that or deal with that situation, but then also whatever else, whatever topic you want to do.
Let's practice it. This happens a lot. And one of the things is, and we really sort of try to stress our candidates against this when we're doing our case list reviews over the summer, is there's just so much out there on the internet about don't tell them anything on your case list, which, I mean, the whole point of the case list, I think, is a whole lot like our thesis. And then our exam is a whole lot like our thesis defense. I think we want to tell them stuff on the case list, but a lot of times this will happen. So I think the examiner would just say, so I see at 26 weeks here, you had a preterm PROM with a breech presentation, and it looks like preterm labor. So it looks like eventually you had to deliver her. When someone comes in at 26 weeks with preterm PROM and preterm labor, and you're thinking that there might be an imminent delivery, what sort of workup or precautions do you take to optimize outcome for the mother and for the fetus?
Yes. So if the patient came in ruptured in a breech and expected imminent delivery, I would try to give a MAG bolus as quickly as possible to try to get a therapeutic level
Let's
prior
talk
to
a minute.
delivery.
Let's just for a second. You and I know exactly what we're talking about. We have to rehearse sort of talking in the exam. I would say I would administer IV magnesium sulfate.
Yes. Okay.
This MAG bolus is a little bit too kind of slang. I would IV magnesium sulfate. Carry on. I'll shut up.
So I administer IV magnesium sulfate, 6 grams, and get her to the OR immediately. And I did want to inform you.
What is the purpose of magnesium sulfate?
This would be for fetal neuroprotection.
Great, perfect. And I'm sorry, I interrupted you. You were about to say something else.
Oh, I guess I just wanted to see if I should say to the examiner right away. So this patient, it is not all listed here. She was admitted at 25 weeks with preterm PROM, not in labor, and was known breech. She received magnesium, had completed a course of antenatal corticosteroids, and then at 26 weeks and 3, she began going into labor, at which point we took her back for a classical primary C-section.
Perfect. That's all really important information for the examiners because they want to know that we at least try to get steroids in. What other, so you, IV magnesium sulfate neuroprotection, steroids for fetal pulmonary maturation. What other treatments would she have gotten during those 10 days?
And latency antibiotics were also given during the admission.
Great. What are the latency antibiotics that you use in your institution?
She receives ampicillin and things that used to be automatic.
Okay.
Ampicillin, azithromycin, and yeah.
Yeah, that'll work. Good. Right. So were you taking care of her during those 10 days or were you only involved in her delivery?
I came on service while she was on antepartum, so some midway through her admission.
Good. So very briefly then, when you were doing daily surveillance with her, what particular things were you looking for which would be criteria for delivering her immediately?
Certainly any sign of labor, which she did, begin having contractions and required more prolonged monitoring. We were monitoring fetal heart tones twice daily with EFM. We were monitoring for fever, foul-smelling discharge, any sign of developing infection. We are keeping an active type and screen.
Good. Anything else?
Her vital signs, keeping an eye on that for tachycardia as well, in addition to fever. And any, kind of maternal, obviously I just said signs of preterm labor, but anything that the patient complained of, such as low back pain, vaginal bleeding, for abruption, all things.
Good. Those are some of the things I was waiting for. Do you do daily fetal assessments or surveillance on your service in this situation?
Yes.
Good. And what particularly would you be looking for on that, which would be a clear flag for you to go deliver her right away?
Signs of fetal distress. You don't necessarily expect to see a classic, what you'd consider reactive NST for somebody further along in their gestation, since it's not validated at 26 weeks, but looking for good variability on not having recurrent or prolonged decelerations.
Good. That sounds good. So we could describe that as a persistent category 2 or a category 2 to 3 fetal heart rate testing. That actually sounds great. Good. I think you've covered everything that an examiner would want to know about how sort of you set this patient up and recognize delivery is going to occur at some point, and I'm going to prepare for that. You've covered your standard measures for preterm PROM. You've covered your daily surveillance. And you've described very nicely sort of what you would do acutely if you felt you needed to deliver her. I think they'd be very happy with that discussion. And again, in our cases today, I've sort of tried to push us a little bit toward the higher level of difficulty and problem solving. But honestly, your exam is going to be like 2/3 to 3/4 what we just talked about. It's actually kind of simple stuff, and we just have to be able to sort of regurgitate what we know we do.
Okay.
That would be great. Good. Thanks very much for doing that with us. We got a minute. Do you want to chat about anything else about this case?
No, thank you for going over with me. I just hope that they aren't annoyed by the lack of information.
No. They see this all the time. You just, the important thing, and it's a little bit more because you have to know the case when it puts up there and remember what to talk about. Is you just fill in the blanks. As soon as you do, it appears on the page in their eyes, and they're perfectly good. It's like it actually is there. Great, thank you. Let's get Dr. Castillo for just a minute. Jamie, coming to you right now. I'll go grab your case list for a minute. It should be right here. There we are. Gotcha. Jamie, can you hear us okay?
Yes.
Good, thanks. Let's do a case, and then we'll take some questions for a few minutes at the very end.
Whichever one. I haven't done OB, but I know everyone's been doing OB, so whichever is okay.
Good. This is your time. You do what you want to do.
Okay, then OB, please.
OB, no problem. We don't mind an OB heavy evening. It's really okay. Here we go. All right. Any problem, topic, or case that you'd like to look at here?
No, really. Just pick whichever.
Okay. Let's see here. Let's try and find something completely different to talk about here for this evening. Let's see. I'm curious, can we do case number 40? Because we can probably get that done before we run out of time here. There's a lot going on in this case, and it's under infections and stuff like that, but just the words elective induction bounces out here, and you've got two of them right here. They're elective induction counseling. Taking everything else off this case, let's say she didn't have case /3 obesity, and she hadn't yet developed her endometritis. When you say elective induction counseling, how do you counsel the patient about the idea of an elective induction of labor? What does that involve?
So I counsel them around 37 to 38 weeks, depending on their checks regarding elective induction, which could be anywhere starting at 39 weeks. I do discuss with them their cervical check, whether they are a favorable cervix, so Bishop score greater than 6, and then their risk factors, for example, something like obesity, hypertension, obesity, or nulliparous state. Anything that could basically affect their labor process. Then I discussed the risk benefits of induction, discussed that if they were, for example, nulliparous, that their labor could take longer than 24 hours, but that is of normal progress for someone who hasn't had a baby before versus someone who's had a baby before. And in that process, discuss the possibility of vaginal delivery versus C-section, depending on the indications.
Good. Okay. So in the absence of any other risk factors, how would you select this patient as a candidate for elective induction of labor? She's a permagravid, she's 39 and 5. Let's say she's had a completely uncomplicated pregnancy. Would she automatically qualify in your mind to be offered elective induction of labor?
I do offer everyone that that induction at 39 to 40 weeks. Depending on their check, I may discuss, whether they've been having irregular contractions, their comfort level as far as any back pain, any complications throughout the pregnancy that may be, bothersome to them, and then gauging on that, having had a long-standing relationship with the patient throughout her pregnancy, we discuss the risk benefits and discuss from there in shared decision-making manner what their desires are.
Good. What I really like about what you just did there is you brought sort of your personal interaction and knowing this patient as a person in there. You said, given our longstanding relationship and my understanding of her shared decision making, that is really nice stuff to bring up in the examination. It doesn't have to be all objective and clinical. You can let the examiners know that you've known this patient for a long time and you have a good relationship with her, and that sort of it sort of empowers your ability to do good counseling with her. Feel free to throw that stuff out there. It's only a positive in the exam. That was actually a very nice touch in this case. So would her cervical exam or Bishop score factor in any way into sort of your feeling of comfort or favorability about offering any patient like this an elective induction?
Yes. In fact, sometimes I do discuss with them that they have a favorable cervix, but because of that, sometimes they'd rather just go into spontaneous labor. The opposite actually happens. So if that's the case, I discuss with them, every week since I see them around that time, whether they are thinking about it, because as the due date nears, then they start to get a little frustrated, which is understandable. And then I continue to discuss it, risk benefits, and go from there.
Okay. So you said, so having a really favorable cervix might make you a little less likely to offer elective induction because maybe the patient will just elect to labor spontaneously. Is that where you were going with that?
Oh, no, I'm sorry. I actually tell them that it's very likely that they're going to do well with an induction, but instead they're more encouraged to go into spontaneous labor because they're doing it on their own.
Exactly. That sounds perfectly fine. Good. So in this patient, it's totally uncomplicated. Bishop score of 3 at 39 weeks. She's a prima gravida. Interested in elective induction, what would you tell her is the statistical likelihood that she could have a successful vaginal delivery if her labor is induced?
I don't have a number in mind, but I would. This is the nulliparous patient that we're talking about, case 40. Correct?
Exactly. It's a prima gravid patient, 39 weeks. Let's say her cervix is a little bit unfavorable. We're going just to the ARRIVE trial here. This is where the examiners want you to go straight to the ARRIVE trial because we do have statistics that we could use here.
That I'm blanking on as far as the number, but I would
remember the ARRIVE trial is prima gravid patients and it is 39 through about 42 to 43. No, just a rough ballpark figure. Just for this is one of the big things that
30 to 40%, I would say.
30 to 40% chance of having a vaginal delivery?
Well, with a not favorable cervix in an obese patient.
Oh no, I'm making her just totally uncomplicated, healthy prima gravida at 39 weeks overall. Thinking about elective induction of labor, rough statistical likelihood that she'd have a successful vaginal delivery.
More than 50%, I would say.
I would absolutely hope so. Now, in your practice, do about 50% of your prima gravidas who get induced get a C-section?
No, I would say.
No, I think it does. Less than that, probably.
Vaginal delivery.
So it would be much more than 50%. I'm assuming the likelihood of a vaginal delivery.
In that case, would I just say ballpark? I would say 70 to 80 and hope
that
that's okay.
Good. Yeah. Yeah. Remember, the ARRIVE trial was a 4% difference. 18% C-section in the 39-week induction group, 22% C-section in the labor spontaneously up to 42, 43 weeks. That's probably why the number was a little bit higher. Centers right around, I mean, it's within 2 percentage points of 20%, which really means that 1 out of every 5 prima gravid women in these like 26 large university hospitals across the United States at 39 weeks ends up getting a C-section, which extrapolates to that maybe 1/5 of all prima gravid women in the United States who labor actually for some reason or another get up with a C-section, which is kind of an impressive percentage, but it is the number. And I think that's a fine number to use in the exam if you just want a ballpark. I think it's really important to know the ARRIVE trial. I know the 18 versus 22. But the other thing the ARRIVE trial did say, and I would always quote this in the exam, and this is a verse of almost verbatim quote, is that a less favorable cervix was associated across the board with a higher likelihood of C-section. But that was in the elective induction group and the spontaneous labor group, because a more unfavorable cervix does mean it's more likely that something's going to happen along the way for which you get a C-section. So that applies to the entire study, not to one arm or another of the study. And I think those are the 2 things that I would throw out there from the ARRIVE trial. And that's really what they want us to know. But they'll sneak the ARRIVE trial in there just by asking you an innocuous question about sort of, you've got a healthy 39-year-old, how do you counsel her about the elective induction? And oh, by the way, what are the odds that you counsel her about it? And that's where they slip the ARRIVE in there.
Okay.
Good. Jamie, I think that was good. We got some good stuff done there. That was nice. Thank you. Anything else you'd like to talk about? We've got a few minutes, but I do want to do some questions before we finish for the evening.
No, that's it. Thank you.
Good, thanks very much. Let's go up our question list. Let's see, we need to hit Dr. Carney first. Alexandra, I think you had your hand raised for a question. I'm trying to unmute you here. If you can unmute yourself for a second. If you'd like to ask a question, Dr. Carney. There you go. Hi, Alex, go ahead.
Hi, can you hear me?
Yes, I can. Go ahead.
My question was, if we are concerned about GTN with a plateauing quant, the other candidate mentioned a chest X-ray, which I would do. Is there any other workup we should do before consulting GYN-onc?
Well, I think if we had gotten a little further into it, what I would said for, I think Matthew was talking about that, was we really want to exclude everything else first. So I like his repeat ultrasound. I go to the hysteroscopy. I'd evaluate the endometrial cavity. I would then really look carefully for the likelihood of an ectopic pregnancy. If it really were GTN, I think her numbers would be going up rather than down likely. I would probably treat her with methotrexate. If she failed methotrexate, now we're not sure. Or if her titers were going up and there was nothing else going on in the adnexa, and I wondered about it, I would consult GYN-oncology. So I think along in there, treating it as a pregnancy of unknown location and keeping in your mind that this could be GTN because we never got tissue on it. That's one of the nice things about the case from an exam point of view, is it allows the examiners to go into sort of that black hole area. We don't know anything about the tissue, but GTN is so unlikely that I think we'd have to go through the methotrexate and the other stuff first, and then they might ask us what signs or symptoms would someone with GTN develop, and then we could talk about the real obvious stuff that would be left over from a molar pregnancy. Was the uterus size larger in days? Did she have large thick uterine cysts? Did she have signs of hypothyroidism? Was there anything on the pathology report that was suggestive? And if you do a pelvic ultrasound, do you see signs of like placental-site trophoblastic tumor on the chest X-ray? Does anything turn up? You're getting really into kind of nebulous territory there, and I don't think they take it that way. But I think GTN comes at the end after you've done the ultrasound, the hysteroscopy, really tried your best to check out the endometrial cavity, and then maybe treat it as a pregnancy unknown location, and you're still not getting anywhere. Then I think we consult GYN-oncology.
Okay, thank you.
Good, thank you very much. That was a good question. Let's go to Dr. Walker. Alyssa, I'm going to unmute you for a minute. We'll do a question if you have one. Dr. Walker, Alyssa, I'm going to take you just a minute there to unmute yourself. Okay, let me go down to Dr. Roseberry, then we'll come back to Dr. Walker. Hannah, I'm going to unmute you there for a minute. Dr. Roseberry, I think you had a question. Yes,
Hi,
Hannah, go ahead. Yeah, go ahead.
So I typed my question, but I'll just restate it. So my question was, if you ever, for the case about the miscarriage with the no pathology on the DNC, if you had found on your repeat ultrasound that they had a thin endometrial stripe, but there was some concern for vascularity, would it be reasonable to consider a trial of misoprostol for this patient instead of taking them back to the OR if you had to put them back under anesthesia? I could see a scenario where you might have office hysteroscopy that could be lower risk, but trying medication management first.
I think you'd be okay as long as you were ready to discuss sort of risk versus benefits, likelihood of success with this, because she already has apparently a completed SAB, and we already did a DNC and we didn't get where we wanted to. What's the likelihood that then medication management would succeed where this had failed? It sounds like it's a more complicated case, and I think maybe after the ultrasound we might lean toward the hysteroscopy because it gives us more immediate definitive information. But as long as you counsel the patient about that this is an option, and you give it like 10 to 11% chance that it might not work, and you counsel her about how the medication works and the effects of it, and she elected to proceed from that, you would not lose anything by spending 48, 72 hours trying that with her. I think that's fine too.
Right. That makes sense. In my practice, it would be faster for sure. And within 48 hours, I could have some definitive answer about a dropping HCG, whereas it may be 3 or 4 days to book her for an OR case.
Feel free to bring that up. Just be able to defend it with sort of, the likelihood of success and your patient counseling about that. You'd be great.
Thanks.
Very nicely. Thank you. Good. Dr. Evros, Joseph.
Hi,
hey, there you go. Hi, Joseph.
Hi, I was just wondering.
Dr. Joseph, yes.
Hi, I was just wondering if you could repeat the stats from the ARRIVE trial again.
Sure. The ARRIVE trial was, I think it was 3,000 women in each group. It was elective induction of everybody at 39 weeks versus spontaneous labor at 39 to up between 42 and 43. And these were all primogravida women, gravida 1, para 0. And the C-section rate in the elective induction group was 18%. The C-section rate in the spontaneous labor group all the way up to 42, 43 was 22%. So 18% versus 22%. There's a 4% lower C-section rate in the elective induction group. And that was a big outcome of the ARRIVE trial. The other important thing, though, is the Bishop score actually does pertain, because the less favorable your Bishop score, the more likely you're going to have a C-section. The rates would go higher, regardless of whether you were induced or whether you labored spontaneously. So that's always important to mention to our patients.
Thank you.
Oh, good. Thank you. Let's get Dr. Placette. Jacqueline, I'm going to get you on. Yeah, Jacqueline, go ahead.
Can you hear me?
Jacqueline, did you have a question?
Yeah, I just had a quick question. You had mentioned earlier, I mean, this seems so silly, but you'd asked you had mentioned that the Dr. Sharmuth had said the GYN case list is basically, or the defense of it would be all about the ureter, and that the OB is all about preeclampsia. Is there anything in the office, maybe?
Yeah. In office practice, yes. I think we talked about this before. Office is hard to study for, because examiners, it's going to be either REI or just generalist, basically, in there. But they just inordinately take your office practice cases as just sort of basic jumping off points for talking about whatever they want to talk about. So if you've got a patient in there who's got PCOS, they could actually just decide that they want to talk about primary amenorrhea, or they could talk about obesity, or they could pick some little other thing off the case list. So it's very hard to study for, because they just sort of take left-hand turns. And the way to study for it is, what we've noticed is, and I remember this in my exam, the classic thing is they'll take your patient and they'll either make her a generation older or a generation younger, and then ask you something about that. So I think my impression from my office exam was I spent less than half the time actually talking about patients on my cases, and most of the time I was talking about just hypothetical random stuff that they just sort of picked a patient. I see she's 36 years old. Let's talk about this in a 36-year-old, and it had nothing to do with my case. That's kind of the flavor of office practice. But a good way to, I think, really to study is sort of move your patients around. If she's 26 years old, make her 66, and think about, given the problem I'm dealing with, how does that work out to the 66-year-old? And for the 66-year-old, make her 26 years old and sort of practice that. And you'll really broaden your ability to discuss office that way. That, I think, is good advice. Thank you for bringing that up. I think that was a good thing to discuss. Let's see, Dr. McCune, Caitlin, you had a question, and I think we're almost done here. Caitlin, unmute yourself if you'd like to, if you had a question. Oh, there you go. Hi, go ahead.
Hi, I was just wondering, case with GBS unknown, with like a risk factor, like a history of GBS positive and a prior pregnancy, or she's prolonged rupture of membranes. We had kind of talked about discussing risk benefits if she's allergic to penicillin, but would you not consider vancomycin in that instance?
You might need to, yes. I mean, if you could get no information about her allergies and you didn't know whether clindamycin or not, that's getting really, really nebulous, and this usually wouldn't turn up in real life, because you can usually get the information that you want. But if not, you might need to think of as your ultimate agent, vancomycin. You might, yes.
Okay. In my institution, we didn't have Clinda sensitivities really, so like any patient who was pen allergic that was a high risk got vanc, unfortunately.
No, exactly. You have to be sure that the patient gets adequate treatment, and if the sensitivities aren't right, then it's like you're not treating the patient. So I think you actually do have to go there.
Gotcha. Okay, thank you.
Good job, thank you. Dr. Fish, Megan, and then I need to hit Aaron up at the top there. Dr. Prayson will be done. Megan, go ahead and unmute yourself if you had a question. Dr. Fish. There's, I think you almost got her. Oh,
Hello.
Megan, go ahead.
Yes, they had already answered my question. I was just, had the question about the ARRIVE trial and what the exact statistic was, because I know they're going to ask about that. I think that's an important thing to know for the test. So.
We should just read it a couple of times before the exam. Be ready to spend like 1 minute on it during your exam. I absolutely agree with you. Thank you. Yes. Dr. Prace, Aaron, I did not get to you, and you had your hand raised for a question. Go ahead, Aaron. Hi, Aaron, go ahead.
Hi, I don't remember if you mentioned a specific percentage or risk for being GBS positive in a subsequent pregnancy.
I'm not aware that actually anyone ever brought that up. I don't know a statistic. I bet you somewhere there is one. We can look it up, but I don't know it. I know it's not in the practice bulletin.
Perfect.
Not to my knowledge. And you wouldn't need to know that. And that's something you could say I would look up. The important thing is sort of knowing when we should just sort of empirically treat and when we wouldn't. That's really the clinical management pearl, I think.
No, understood. I thought I misheard that you had brought up.
No, I do not know a percentage on that. No.
Thanks.
No, somebody does, but it's absolutely not me.
No worries. Thanks.
Thank you. There was one more hand raised. I want to be sure we didn't miss anybody. Oh, Dr. Hussain, Samoti, Dr. Hussain, go ahead and unmute yourself if you could, and let's take a question, then we'll finish up here.
Actually, my initial about the can you hear me?
Yes, go ahead.
I actually initially want to ask about the ARRIVE trial, but you answered that already. But since I have you here, just a quick question regarding the GBS case. So
yeah, sure.
Beyond 37 weeks, hasn't been ruptured, was GBS negative in a previous pregnancy, and you know, doesn't have any risk factors, is not febrile. Yeah. Let's say I would not treat her.
Yes, exactly right. Yes. And the key thing is if we're uncertain about one of those risk factors, then, so for instance, if we suspect prolonged rupture membranes, but we can't prove it, would we empirically treat her? I think, yeah, maybe we would. If we rule out the other stuff where she couldn't recall anything about the GBS status in previous pregnancy, and maybe she was colonized, that confers a risk to this pregnancy. Yeah, maybe empirically we would.
Got it.
You know, things like being febrile, you can tell right away, but there are some of those risk factors, if you're not sure, we might want to err on the side of caution.
Sounds good. Thank you.
Good. Thank you. Thank you to all of you. That was a great discussion this evening. I believe I'm back with you next Wednesday. I think we're doing some structured cases, which are always fun. Again, remember, these are archived. You can go review them anytime between now and your examination. Thank you to all of you for joining us. We'll be starting again this coming Sunday. One of our faculty will be doing a case list review again. For now, everybody have a great rest of the evening. And thank you very much again for joining us this evening.